Hello, everyone. Welcome to our Indigenous Behavioral Health series. Today is the second session in a series focused on crisis intervention. My name is Monica Dreyer-Rossi, and I'm the program manager for the Indigenous Behavioral Health series. This four-session series will discuss common crisis situations. It provides an overview of crisis intervention guidelines and strategies, and describe clinical responses to common behavioral health emergencies and crisis in clinical practice. With that, or before we start our session today, I want to reach out to our audience and participants to see if anyone would like to open up today's session in a good way. Anyone who wants to volunteer? Jacque or Kathy, would you like to open up?
I think we're going to talk a little bit today about the importance of opening things in a good way as a part of that trauma-informed care. And so I'd just like to say, good morning and blessings to everyone. Thank you for joining us. And I would ask that the Creator would help you in putting your heart and your mind together in a way that you can hear what we're talking about today and make use of it in your personal lives, in your professional lives, in your family lives. Thank you.
Thank you so much, Jacque, for that. Next slide, please. So this session is presented to you by the National American Indian and Alaska Native PTTC and ATTC located at the University of Iowa. We are a part of a national network of technology transfer centers. If you would like to, please share your name and where you are located in the chat. Next slide, please. This program is funded by SAMHSA, but the content and opinions expressed today do not necessarily reflect the views and policies of our funder. Next slide, please. Please take a few moments to give us feedback on the event at the end of the presentation. We will share a link to the evaluation in the chat. We will also send a follow-up email after the event with the link to our evaluation survey. And attached to that email, you will also find instructions about how to receive a certificate of participation from our center. We will share additional resources in the follow-up email after the training, but we cannot share the recording or full slide deck. Please post your questions and comments in the chat throughout the session. Our presenters will try to comment and answer questions as they go along. And with that, I would like to welcome our presenters, Dr. Winter and Dr. Gray.
Good morning, everyone. Pleasure to have this opportunity. I have had the wonderful connection with the center for several years. I am also a behavioral health scientist, formerly with the Oregon Research Institute, based here in Minnesota, and have enjoyed the opportunities to be part of the series, and will be co-training today along with my colleague, Dr. Gray.
Good morning again, everyone. I also have been working with the center over a number of years, and I'm currently serving as the interim director of the Prevention Technology Transfer Center. I've worked in crisis intervention most of my career in various capacities, from suicide prevention and intervention to mass shootings and mass casualty incidents. And so I'm looking forward to going on through the material today and talking a little more about what we covered last week even. So thank you. Next slide, please. So as you read through the land acknowledgement, we want to pay respect and attention to all of the nations whose homelands were forcibly taken. We know that the entire Turtle Island about 500 years ago was covered with indigenous peoples, and now just a small fraction of that. We want to honor those people that stewarded the land all through the generations, and that we continue through advocacy, support, and education to be better stewards. We acknowledge the history of genocide, forced occupation, and while those injustices are still being committed, we want to say thank you to those that stand with us and are our allies as we continue to work for the preservation of Mother Earth. Thank you for our colleagues from the Meskwaki settlement who wrote this land acknowledgement that's on your screen. Next slide, please.
So I'm going to start out and give us a little overview of the whole series, as well as what we're going to tackle today. And you can see that we're in the second session. So today is going to address some specific clinical topics when helping clients, as well as significant others when dealing with a crisis. Hopefully you can join us next week when we'll be focusing on case illustrations. And then the following of that week, in 2 weeks, we'll have a chance, as we do with all of our installments, spend some time in getting you to share your thoughts and ideas with us, as all of our faculty will be present, and we'll have some questions to discuss and really encourage you to weigh in. Also a chance, if you have specific questions that didn't get addressed, you can bring those to that session. Next. So this is an overview of today. We're going to run through these 6 topics, a focus on trauma, and then delving into other specific topics, significant others, how to support yourself when you're having to deal with a lot of clients that are dealing with crises. So counselor strategies, because that's so important to avoid burnout and to maintaining your great skills. And then the role of supervision and some legal issues, and then we'll summarize. So next slide, however, we're going to just start with something a little different before we start the core content. So last session, which was 2 weeks ago, we talked about challenges of a counselor when helping a client deal with certain crises, and we spent quite a bit of time focusing on depression and suicide. So next is a cartoon that paints a satirical picture of perhaps a current and maybe not a great trend in the helping profession. So next slide is the cartoon, and I'll read you because it goes across the top. So you can see to the far left, it's a physician, and there's a client on the other side of the desk, and the physician says, depression is nothing more than a simple chemical imbalance in the brain. Next, he says, I'll send you away with a prescription for these little pills, and very soon a pleasant sense of confidence and control and normality will return to the situation. And they show the client is very surprised and happy. And then down at the lower left, the client stands up and says, oh, thank you. I'm so grateful. You're so marvelous. Thank you. Goodbye. And the last scene shows the physician leaning back, feeling so pleased. All right, so next slide is a request to have you comment on that. So either you could unmute or put something in the chat box, or the thought from Jacque and I is, well, what message or messages do you think are conveyed in that cartoon? Messages about people seeking help and response by professionals.
While people are typing and or deciding what they want to say, I'll just comment that, you know, I think we have a real instant society, that we expect an instant resolution to everything. And, you know, to think that it might take months or years to work through a problem is not, you know, we don't want to deal with that. We want something that's easy to do, an easy fix. Some of the comments we've gotten so far, one, Rusty says meds can fix everything. And Jay says it's an arrogance of professionalism. Maybe that the physicians think that, you know, they can do it all.
Right.
I think a lot of times the primary care physician is the first person to see someone. And so their habit may be to just write a prescription rather than making the referrals and the follow-ups.
Whitney raises a good point about implies that there's one fix for all kinds of problems, or at least one fix for depression. And that, of course, is quite misleading to the realities of something as complex as depression.
And Nelda says depression has a simple fix.
Right.
And Carlene said that it doesn't look like there's any empathy for the situation, what the person's dealing with.
Right. Doesn't even get at the root of problems. You know, to some degree, there's the health system over reinforces what we're talking about, which is a shame.
But not that we think all physicians are that way, or, you know, all providers are that way, but, you know, it's something to think about as we go ahead and we talk about trauma-informed care and dealing with crisis situations.
That's a good segue into the next slide. We'll get into our particular focus on trauma. And this is going to be split between me and Jacque. I'm going to lead off with some overview topics next. So let's first start with a definition. This is from the American Academy of Pediatrics, but I think you can find a lot of definitions from various professionals and experts that fit this. It's an event or series of events or circumstances that an individual experiences that is harmful on a physical or emotional level, and that can have lasting negative effects on the person's functioning, well-being, mental status, physical status, and spiritual health. It can occur outside a relationship, you know, in the environment, like a natural disaster, or can occur within the context of someone's personal life, a caregiving relationship, for example, being exposed to domestic violence, and in the context of relationships outside the family. So interpersonal, but not necessarily within the family, such as being discriminated against or being victimized by racism, or for young people, so often bullying can be a source of trauma. And it can occur in the context of historical loss of culture resulting from colonization. So it can be acute, chronic, it can be coming from multiple and diverse sources. Next. So trauma of all kinds, they can contribute to health disparities. So we're hoping you can comment in the chat box or feel free to unmute. In what ways do you think trauma contributes to health disparities? Not being able to get proper care among certain groups because there's disparities in the system, biases that occur that lead to difficulty getting access to care or effective care. How can trauma, though, contribute to this problem? What are your thoughts on that? I think we all can agree health disparities can occur for many different reasons in a lot of different contexts, but now we're seeing how might trauma also be a driver of health disparities.
Factor is trauma impacting your immunity to where when you're under the stress of trauma, your natural immunity drops and you're more apt to get sick.
Yeah, that's a great point. The disparity may come from or be contributed by the sufferer, the person that has been traumatized, because it might lead to not making a good decision to go seek help, or maybe feeling more reluctant to get professional advice. Trauma elevates cortisol, stress levels, and those unhealthy levels can impair people's judgment, prevent people from seeking help due to fears of mistreatment. Sure, you've been traumatized by something, and you may fear that you'll get reminded of that. You'll have to revisit it, or maybe there's as some people are saying, there's the stigma of what happened that might have to come up as you're getting some care. It might be important, as we'll talk about with the informed trauma approaches, but it can be difficult to want to talk about these things, to want to disclose.
Ability to get help.
Kathy makes a good point.
Can impact a lot of health disparities.
Yes. Think of how it can make it difficult to focus, or it can make a person be too hypervigilant. It can it can add to the extremes. If you're hypervigilant, that might mean you're overreacting to something, and that can just add more problems to the mix.
But that inability to focus actually, as Kathy indicates, leads to other accidents and other health disparities along the line because of those injuries and things that occur. It's kind of a cascade effect.
Right. A domino effect.
Uh-huh.
Yeah. So in some ways, we're talking about it contribute to barriers to seeking help. And then that, of course, can be a form of disparity. Okay, let's try next slide. It's excellent input. Thank you. All right. So one more. You get to chat a lot and share with us. So a question about the possible differences in experiences and how one reacts to those. If you think about trauma experienced by reservation-based natives versus urban natives. So think of the two general type of lifestyles or settings in which American Indian Alaska Natives live, reservation versus urban. Do you think that the trauma experienced are different in a general way? Obviously, there's individual differences in experiences, but do you think there's any general principles that lead to different kind of trauma experiences from those living on reservations versus those that are urban based. If you think so, maybe in what ways can you articulate how that might look, if you think there are some differences? By the way, I haven't seen anyone in the literature talk about this, so we're getting some new ground here.
Well, and some of this is hard to define when you have people from our natives in urban areas that'll go back and forth between the reservation and the urban area.
That's a good
So
point.
it makes it more difficult to really totally separate out.
Someone brings up lack of trust of the government and of non-native people. So you might have more or less of that based on whether you're urban versus reservation living.
So even if the services are there, you may be less likely to use them.
Right. There might be, as Valerie, I think it was Valerie, less perhaps cultural based treatment in urban settings, and so you're not really feeling as comfortable about seeking help. And then Barbara mentions, I think, what you just did, Jacque, the lack of services between the two really can exacerbate health disparities. Excellent. Got a lot of good input. People are sharing with some excellent insights. Thank you. Now, someone mentioned trauma is trauma, regardless, and there's, I think, a good point there. And then, to the extent someone has certain support systems that are enabled by where you live, that surely can make a big difference on how someone is experiencing or trying to cope with trauma. And maybe that has, for some, a relationship of whether you're reservation-based or urban-based.
Kathy, did you want to say something or?
No.
Okay, I just noticed you were off mute, so I wanted to give you the chance.
Yeah.
Oh, thank you for telling me. I just got my speakers working. Sorry
Excellent.
about that.
It's okay, just wanted to give you a chance if you wanted to say something.
And then Joyce mentions the trust value and how that could vary.
And that they, Makeba says that they don't take into consideration native culture,
In
customs
urban
and
settings.
traditions.
Yeah,
In the urban setting, yes.
right. We're going to get more along those themes, and if you've been with us throughout our behavioral health series, you'll be reminded that we often point to common sense as well as to now research literature that shows health services that are not culturally informed usually do not yield as much favorable outcomes, and quite relevant in the American Indian Alaska Native arena as well as other cultures.
And lack of access to the culture in the urban settings.
Exactly.
I was wondering, what role does Native spirituality play in health disparities that was mentioned earlier? Is that what you were saying, that there wasn't enough research on that? Is that what you were reflecting on?
No, I was reflecting the research is definitely supporting the importance of that.
Yeah.
And we tried to emphasize that throughout the series. And it would make sense whether you're treating depression, substance use disorder, trauma, having treatment, as well as perhaps social interpersonal connections that are culturally based. The evidence is now showing that really does improve outcome across, not just AIAN populations. That's showing up in other cultures, but surely a major hallmark of research outcome in this field. Yes. Let's go to the next. Thank you, everyone. let's talk a little bit now about trauma. I'm going to give you some overview themes and a reminder that when you think about trauma and its impact or association or intersection with behavioral health, one needs to consider the bi-directionality of it. And so there's two bullets here, and they make a distinction between, well, many behavioral disorders may later predict trauma. That is, the person might have certain habits that are maladaptive, and that may increase their probability of getting exposed to trauma. And then at the other end, you could talk about early trauma can later predict or contribute to somebody having behavioral health problems. So you have the so-called high risk hypothesis, the first one, and then you have the second one, the trauma hypothesis. And it could be a mix of the two. So somebody could experience both of these kind of pathways to trauma in their lifetime. As well as there can be an interaction. So you could have a behavioral health problem or disorder that might lead to some early exposure to trauma. Well, the trauma then helps, or unfortunately, helps to contribute to an escalation of your behavioral problem. So there can be also this interaction between the two hypotheses in a given person. Next. So a little bit on a focus on historical trauma. And I think this slide does a nice job of talking about the cycle of it. The history of it then contributes to the strong stress reactions and grief that present day individuals have. And then that can contribute to increased risk for all kinds of problems, such as substance use, negative emotions, mental health issues. And then that can contribute to other traumas, more acute traumas. So this is basically taking the historical trauma precedes then the high risk hypothesis, and then that contributes to even more trauma. So you have history contributing to current issues, and current issues then elevate one's probability and risk of it being exposed or having exposure to additional trauma, present day trauma. So and then of course that trauma can lead to more issues and concerns and negative memories about historical trauma, and then that just further aggravates all of those problems. It further aggravates the cycle. So historical trauma, can be, in this light, an elicitor, an onset factor to a cycle that contributes to health problems and additional trauma exposure. Next slide. A reminder from Maria Braveheart, who just brings to light the importance of keeping historical trauma in mind when you're dealing with a Native client who has a current crisis or emergency. And so that person's psychological well-being, while impacted by the current crisis, may also be compounded by historical trauma. And so it's important that the current crisis be addressed, coping skills be addressed, but don't ignore perhaps the elephant in the room, the historical trauma that might be aggravating that person's current ability to cope with a crisis, as well as perhaps being a barrier to your efforts to get relief, help the person get relief and get in recovery. Next. And then as we now move into our next topic, we're going to spend a little time on trauma-informed care. I'm going to lead off with a nice summary that's provided by Melanie Hazel. And she discusses the importance of the kinds of steps that are needed by counselors and clinical settings to do a good job with trauma-informed care. Her quote is excellent at the top. You shift the focus of the client's perspective from what's wrong with you to what happened to you. And then several foundational steps are described by Melanie: building awareness and generating buy-in for trauma-informed approach among your staff, supporting a culture of staff wellness, making sure you're hiring and maintaining a workforce that embodies the values of trauma-informed care, create a safe physical, social, and emotional environment in the workplace, and then do a good job with number 5, which we're going to spend some time on identifying and treating trauma.
Next slide, please. And this next section on another way to view trauma-informed care is being a good relative was prepared and presented by D. Bigfoot with the Indian Country Child Trauma Center. Next slide, please. So when we talk about ways to be a good relative, we talk about offering someone water, offering a song or hope, good words. You know, I care about you. You know, I want to be there for you. Things that let the person know that you're connected to them. Offering prayers or welcome, a spirit blessing, and giving them choices, accountability, supporting that confidence, openness, acknowledging what's happened to them, providing safety, reassurance. All of that is being a good relative and are things that we may do just when we're thinking about being good relatives. But it's also important when you're giving that care to that person that's been traumatized. Next slide, please. So communication is really important. And the feelings and expressing feelings are an important part of that communication. But when someone's traumatized, they're feeling overwhelmed. And there may be that shutdown of communication where they're not communicating at all, or that outburst of negative exchanges. You know, they get angry and they react to that whenever you try to help. And many times that anger is a means of communicating the withdrawal, indifference, hurt feelings, pulling up barriers or hidden feelings. All of that interferes with that. It's how they're communicating, but it interferes with a good two-way communication. And children and adolescents who have trauma histories are still developing emotionally, physically, sexually. That can all be very confusing and unsettling. And they may withdraw from any offers of assistance because they're trying to figure all of this stuff out, and it's really confusing for them. Excuse me, next slide, please. And there's something else that we hear about as providers, and that's secondary or vicarious trauma. And that's where the self-care comes in, because that secondary or vicarious trauma are things from the person telling their trauma story that impact your feelings, thoughts, behaviors, and relationships. It impacts your own personal trauma and brings all of those things out and tends to traumatize you from the person that was traumatized, not from the original trauma. So that's secondary or vicarious. Now, self-care is when we understand when they share their trauma experiences and we listen and we have empathy for their suffering, and that can create that feeling of hopelessness, fear, helplessness, urgency within ourselves to do something, to fix it, to try to make something happen. Self-care is also recognizing that the media and other sensory images can cause that secondary or vicarious trauma. I know being in Oklahoma after the Oklahoma City bombing, because that was the beginning of that 24-hour news cycle, and they were just replaying the images of the bombing in a continuous cycle 24 hours a day. There was a vicarious trauma because you were just re-traumatized every day, every time you saw it. And the other thing is the violent encounters, like toward the water protectors up at Standing Rock, when they were trying to stand against the Keystone Pipeline. There were a lot of things that occurred that created more trauma within that camp. And self-care is important for modeling and demonstrating for people with trauma histories and their families, that there are healthy and productive ways of caring for yourself and others. And I know one of the things I worked with any of my supervisees or students was, we talk about self-care. And not only did I talk about self-care, I had things on my calendar, like my massage every Monday. And everybody on my staff and all of my students know that I didn't schedule anything for Monday afternoon, that, nothing preempted that. So, so they actually saw me taking care of myself, and that also gave them permission to take care of themselves. That they saw that not only did I talk about it, that I actually did it. Next slide, please.
Jackie, quick question for you.
Uh-huh.
As you're talking about self-care, it must also relate to how someone manages their caseload. One must be quite attuned to making sure you don't overload your caseload with these kind of cases, because it's just likely straining then somebody's ability for self-care.
Absolutely. And, there's some settings that's all you get. And so you have to really limit, that if that's the only types of cases that you're getting, you may need to cut down on the number so that you can do more of the self-care or care of that staff in dealing with that. Because, and also in that self-care, that spiritual care as well. Some of the things like, smudging and cleansing and things like that. Kathy, she doesn't know how it fits into the discussion, but she'd also highlight the way resiliency fits into the trauma-informed care. How people, even when experiencing or exposed to trauma and events or situations, can have a reaction that helps someone overcome those effects. Prayers to ask the Creator to help work through exposure, spending time in the natural environment, talking to elders, other supportive people, practicing art, spending time with animals, smudging, meditating, music.
Yeah.
Excellent. I think that's etc.
Yeah. We'll be talking about resiliency quite soon.
Yeah. But, all of those things apply. And, that the other side of crisis and trauma is resiliency. So it's how do you turn that into something positive that you can make use of? So part of that is understanding transition periods. And it's always been a part of Indigenous ways and practices to have those transitions. Things such as brushing off an individual Acknowledge that there's something healing that the person needs, and it's a time for attending to that person. So taking care of them and brushing that negative spirits and all away from them. Naming. That transition from one time of life to another is a time where people are given a new name. And it's very typical, and change in status, as to who they are and what they have grown through as part of that naming. Starting out a song, where typically you've got one singer or drummer that starts with the drum beat, and then others follow, allowing that head drummer to lead the song. And being silent, not immediately responding when conversations are going on. Allowing for silence. And that's something many times people aren't comfortable with, is that silence. Okay, next slide, please. More transitions that have always been part of our ways. Prayer. We open up our sessions asking if someone would like to help us open in a good way. It could be prayer. It could be a song. It could be some good words, like I mentioned earlier. Things like that. Or some type of ritual or ceremony. Making an offering of water or some other object to kind of say this time is sacred, or it's important, and we're setting it aside. Gift giving is another transition where someone's recognizing that they're present, or they're leaving, or honoring the time that that person will no longer be around. So, the giveaways. Many times you'll see graduation, there'll be a giveaway, or at a powwow, there'll be a giveaway for recognizing a certain transition in a person's life. Coming of age ceremonies. So they're passing from one part of life to another level of awareness of themselves and recognizing that coming of age. Next slide, please. So behavior and thoughts are engaged in and are being changed. So that relationship that may be strained between family members due to that trauma or victimization, and now there's an opportunity to decide what are some kind of appropriate boundaries for rebuilding that relationship, or maybe moving away from that relationship if that's what's needed to recover from the trauma. Acknowledgement of the history of distrust in general and how that affects your other relationships, especially if children and youth are involved. And this is where there's an opportunity for changing the negative or unhealthy perception of relationships toward what's desirable in a positive and reassuring relationship. So this is where we come away from the negative and we follow through in our behaviors in the positive. And those youth and children can learn what the positive is and can lead toward greater resilience. Next slide, please. There may be discussions about illegal, harmful, or oppressive behaviors that can raise people's anxiety. They don't want to talk about things that are uncomfortable. And there may be limited confidence or understanding on how to shift toward more open conversations. I know one thing I would tell parents in dealing with families where there've been sexual abuse is that they'd say, well, when do you start teaching, about those things? And I said, from birth. And they said, well, what do you mean? And I said, if the baby doesn't want to be held, you move in and you say they don't want to be held right now. You know, you let your toddler know it's okay if they don't want to kiss you goodnight. And they're like, what? And so they go home and they try it. And the first night the kid says, no, I don't want to kiss you goodnight. And they come back and it was just destroyed them. And they found out that the next night the kids were right back kissing them goodnight. They were just testing to see if you really meant what you said. Checking those things out, learning that I can say what's okay or not okay for me. That shift toward more strengths-based and non-judgmental understandings and practices. That's that resiliency. Going toward that positive. How do we create those situations so that we move toward individuals and practices with and improve those things where people have trauma histories? And a shift toward recognizing the impact of the trauma and the victimization over relief and insight. And we can self-assess. We can say, okay, give me a minute. What's going on with me? I need to self-assess. And am I reacting to the situation or am I reacting to the past trauma? And then I can make a choice as to what I'm going to do after that. Next slide, please. You want to read this?
Sure. A chance for some sharing and insights from the group. Again, feel free to either unmute or put your comments in the chat box. So trauma has a strong link to substance use problems. This association has been found in a lot of studies spanning all age groups and those across the ethnic, racial continuum. In what ways do you think trauma can contribute to substance use problem among American Indian Alaska Natives? What are your thoughts on that? So just focusing on the intersection of trauma and substance use issues, substance use problems. Of course, there can be many sources of a substance use problem in any given individual, or certain cultures may have a preponderance of some causal factors. But what about trauma? How can that have a contributing role?
You know, I think when you have certain substance abuse problems, sometimes the trauma is reinforced by the type of substance that you use, because of the societal negative consequences towards certain substances. So I see a lot of trauma lifestyle with opioid dependence and heroin addiction, as an example, or somebody with methamphetamine addiction because of the way the person has to live, and the effects of the substance on their life, as opposed to early substance use with alcohol that hasn't progressed into late stage alcoholism. So the more severe the substance use, and the lifestyle that goes with it, what I have noticed is the more traumatizing that experience can be, if that makes sense.
No, yeah. In other words, the more severe the trauma, you may get a tendency to abuse, I'll call it the more devastating, intoxicating type drugs.
No, not necessarily. I mean, you can have a lot of trauma and only use alcohol.
Okay.
But it's really the nature of severe mental illness, untreated, and severe forms of substance use, but also the heroin addict experience, if you will. The person suffering from heroin addiction and the person suffering from late stage alcoholism may have a different experience in life with those two substances.
Yeah.
Although both severely negatively affect somebody's well-being.
Yes. In many ways, I think your commenting on the principle of any of the so-called intoxicants out there. If you use it in a severe chronic way, you can get chronicity and a lot of behavioral issues downstream. Even like you say, alcohol legal. A lot of people use it moderately, but of course, if you don't use it moderately, you can get as severe level problems as much as someone who's addicted to heroin.
And lots of comments about numbing emotional pain, escaping reality, things like that.
Yeah,
in the chat
controlling,
box.
trying to control negative emotions. Yeah. Yeah, well, good themes about
And
the psychological
Barbara-
benefits.
Yeah, Barbara talks about how, the lack of mental health providers, and then there's the stigma to don't say anything. And so that just exacerbates the problem and creates that lack of self-worth because you can't talk about it.
Right.
And in rural areas, there's a lack of providers and transportation to get to an appointment. And then there's alcohol, fentanyl, meth for the substance issues. And then it just kind of spirals into the lack of substance abuse treatment options. So it just goes from one, just kind of spirals down.
Right. Some people are noting, which reflects back to the high risk hypothesis. So trauma might lead to substance use problems. Well, then that substance use problem might lead to more trauma or aggravate trauma experiences.
And then Whitney says the individual hasn't learned a healthy way of dealing with trauma and healing from it, and they lean to numbing the pain that comes from the trauma.
Yeah, when you get in that kind of habit, you're using substances just to deal with everyday challenges that, far short of trauma, but you feel the everyday stress or the challenges of this, that, and the other, and then you get into bad habit.
And a lot of that, we lost a lot of our ceremonies and our ways of dealing with trauma that we'd done over thousands of years when we weren't allowed to practice our spirituality.
Yeah, right.
And so, that has then left all of that trauma to continue to eat away. So
and blocking an attempt for a solution or a response.
Healthy responses
to
what that is. Yeah. Okay, next slide.
Next slide. Yeah. I think we're going to jump into the topic of addressing survivors of a terrible event, as well as significant others of a client who's experienced a crisis. So now the focus here is a little different than just that client who's experienced something like a crisis or an emergency. So next, what are some context points? Just a reminder, we're talking about two sort of different types of situations or clients. So one could be a survivor of a natural disaster or a community-wide disaster, a different type of trauma experience. And then there's those that are significant others, and as well as spouse, family members, etc., of a client who's experienced trauma. And those others may also have been exposed to all kinds of issues because they were direct or indirectly involved perhaps in that traumatic experience, or they're living with the person and they're now starting to experience and have to address some of those difficulties in their loved one. Next.
Ken, before you go on, I think one of the things that I mentioned last time was when we developed our crisis team, that right after that happened, we got a call for a traffic accident that several cheerleaders were killed. And we responded to the school and we were helping there. The thing we had not anticipated that happened was the daughter of the man driving the truck that hit the cheerleaders.
The daughter
came in, wanted to talk to us.
Sure.
and she didn't feel like she could say anything to anybody else or get support from anywhere else because her dad was the one driving the vehicle that killed the students.
Yeah. There you go. A unique but very difficult situation, and that person, surely could would benefit from some support.
So that's another, significant other, but not like you would normally think of.
Right. And sort of an indirect significant other to the incident. Yes. Very good point. Next. So to look at these kind of interesting, so-called different types of clients than the usual when we think of client experiencing trauma, we're going to focus on resiliency skills. It's, of course, a strategy you can use across the board when you're dealing with any kind of crisis emergency situation, but I think particularly useful when we're talking about survivors, significant others. So a reminder, resiliency is the ability to bounce back from hardship and trauma. Various associations and experts have defined it. I'm going to read the definition from the American Psychological Association: the process of adapting well in the face of adversity, trauma, tragedy, threats, or even significant sources of threat. The definition implies two phenomenon that have been talked a lot about, and they're somewhat opposing or paradoxical. One is the importance of a sort of hardiness in the individual, or toughness, or an ability to resist being overcome by trauma. But on the other hand, somewhat paradoxical to hardiness is having flexibility or adaptability in the way you're dealing with the situation, your behaviors, your perspectives, and coping strategies. So
Ken, is the first one like the coach telling you to get back up and get in there, you're not hurt?
The hardiness?
Yeah, the hardiness, the toughness, the resistance,
Yep.
you're.
Yep. And now let's extend your metaphor. Where would the elasticity come into play?
Being able to switch plans quickly. I mean, in other words, I can relate to these because of, I think
Cowboy up, man up.
the cowboy up, pull up your bootstrap.
Right.
But, I think the flexibility and elasticity is really, you're not like married to any one way of doing things.
Yeah.
And that you can, in the face of a challenge, you can switch things really quickly. Whereas maybe you don't do that in your everyday life, but when you're in a situation that is high alert, that you have the ability to just switch things really quickly to adapt to a situation.
Oh, exactly.
Myself, obviously, because of
and I think people didn't really appreciate that during the pandemic. With Dr. Fauci coming out every day and saying something a little different, that he was showing the flexibility and elasticity of bringing in the most current research that they had, the information they had, and adjusting the plan. And people wanted, no, just give me plan A. I don't want B, C, D, E as things change.
I think of families and kids in school and how they had to make all kinds of adjustments because there might have been, no longer in school learning, got to do the homeschool, the parents got to adjust, etc.
And that was really difficult for people to make that many adjustments all at the same time.
Right. Oh, and plus people might have had COVID, so you might also been sick. Go to the next slide just to show you a metaphor for all of this. Hit it one more time. There it is. Think of a rubber band that's a sturdy rubber band. So it is flexible, but when you stretch it, that is when you're showing flexibility or adaptability, it it doesn't tear. It still hangs in there, which is reflecting that you're still able to be strong. As somebody, Michael says, you're still able to cowboy up, man up. Cowboy up, man and women up. I'll just make sure we adjust that slightly. Next slide, and this is just some features of resiliency. This comes from an article I read, and they called it the secret sauce of resiliency. They were talking about how people adjust to very extreme forms of trauma, including natural disasters, being prisoners of war, dealing with loss of loved ones, etc. So an expert who's studied this named Southwick was interviewed by a psychiatrist named Charney. Anyway, here are 8 features, and if you look at them, you'll see they represent behaviors and perspectives and attitudes. So it's more than just coping with how you act or behavior-wise, but it's also your attitude and perspectives on things. I wanted just to profile for you number 6 and 7. So makes a lot of sense, right? Strong social supports. And then 7, many people might not think this is a high profile type feature to be on the list, but something called unselfishness. And that's an interesting feature, I think. And the literature talks about this, as well as Southwick and Charney. The notion is that if you spend all your time just thinking about yourself and your own problems, you lose perspective. You miss out on the reward feeling when you're giving to others and being unselfish, and you probably don't help to optimize the ability to bring in social support. So it can probably encourage the breadth and the richness of social supports when you also are showing others that you're not being selfish, or you're not being too self-indulgent. That can, in other people's eyes, show that you have strength and that you're not forgetting about others, even in a time when you are dealing with trauma. And that likely encourages others then to rally around you.
And Ken, I think culturally we'd call that generosity.
Yes. Yeah.
Generosity
exactly.
of spirit.
Excellent. Exactly. And all of us, I hope, realize you can feel good when you're generous. There's a nice psychological warm feeling from that. And if you lose sight of doing that, you lose a chance for that positivity. And a reminder, guided by core traditional values. And so being aware of those values, getting connected to them, where others are also supporting and encouraging those values, can be a big plus. Spiritual, religious, community-based values, and maybe values in your own home and family. So next slide is a chance to sink our teeth into how counselors can make sure that they can do a good job of supporting themselves and being careful about not getting burnt out. So next slide. And
So,
I think, Jacque, I'm turning it over to you. Yes.
yeah. The Bureau of Justice back in the early 90s gathered some information that 80 out of every 1,000 mental health professionals was the victim of some form of non-fatal workplace victimization each year. I think that's probably increased. And I say that because we've done more research on stalking, on other things that may have been, disregarded before the early 90s, that really wasn't thought about. The mass shootings, there are just so many things that are occurring nowadays that, although these are old statistics, I'm going to guess that they may be higher nowadays. Another study looking at 1,100 mental health professionals 61% reported being verbally or physically assaulted by a client or a patient. 29% reported they feared for their lives and at least once during their professional careers. So, you know, these are things that we have going on in our workplace that we have to live with as counselors. I know one place where I did my practice as a student, they'd had someone show up with a gun looking for one of the counselors. When I was in with one client, he pulled out a knife, indicating that if he needed to take care of things to protect his child who had been sexually abused, he could take care of it. He wasn't threatening me, but, you know, that was threatening, just him pulling it out. You know, there are things like that that occur. And we have to deal with our own trauma as those things take place. Next slide, please. When we have a patient that suicides, it's not uncommon for counselors to report feelings of disbelief, failure, self-blame, guilt, helplessness, anxiety, or depression, and concerns about responsibility, malpractice suits, censure from colleagues, damage to the reputation. The first one on all those different feelings, what does that sound like? Does that sound like feelings that someone that may be suicidal might be having? So it can generate some of that in the provider. And the second is, you know, what did I do wrong? What do I need to look? Am I responsible for this? Am I going to be sued? How are my colleagues going to think of me because my client committed suicide? All of those things. And that can complicate how you deal with your personal reaction to suicide, how you deal with the people in your life, with your colleagues, and everything else. Next slide, please. Now, clinicians that were assaulted by a patient often say they experienced a dramatically increased sense of vulnerability in the aftermath, a greater sense of fear and vulnerability, the greater the extent of the physical injury. So the more they were assaulted, the greater their fear. So they become anxious. They may change how they set up their office. And so as far as where they sit related to their client, I know one place I practiced, one of our counseling rooms was a converted bathroom in an old building to where we had to go in single file. And I had to go in first and then everybody else went in. And the last one closed the door. At one time I had 6 people in that room. When I was trying to do family counseling in there. But I knew good and well that there's no way I was getting out there if anything happened. So when I was meeting with a client that I, had been given information that they might be dangerous, I made sure that I worked it out. I was working with the health department, that I worked with the nurse so that I could have her clinical space, which was a bigger room, if I was seeing a client like that. So it changes how we behave. Other times when I was assessing people for, suicide and things like that, I might have a secretary sit in the next room. Not that she could hear exactly what we said, but she could hear if the voice is raised or not, and that she could call for help if voices started getting loud. There are ways that we set up to deal with different situations like that. Next slide, please. So when counselors are working with a client that's been victimized by violence or crisis, it can lead to the counselor also questioning their competency. They can develop anxiety, have intrusive thoughts about the client's experiences, some of that secondary vicarious trauma that we talked about earlier. Next slide, please. So you need to be proactive in attending to your needs when working with your clients that have been victimized. Get your continuing education, have ongoing supervision, consult with experienced colleagues, and go into counseling yourself if necessary. Next slide, please. The Assaulted Staff Action Program, or ASAP, is a support and kind of a psychological first aid for staff that want to use it. And if a patient assault occurs, the ASAP team member contacts the individual staff member to offer support and see if they're getting any needed medical care or mental health care. And that might be a model program for Native mental health centers to make use of. I know that's difficult because of the lack of staffing, and some places may only have one. But you can also connect with other centers and provide that for one another. Next slide, please. So, share in the chat box or unmute. If we look at the list below, some keys to client resilience that we just reviewed. Which of these are relevant for coping as a counselor? Look through some of those. We talked about some of those.
Lestina
says
says all of them. Yeah, yeah.
I think any of those that are relevant for clients are also relevant for counselors. A lot of all of them.
Yeah. It's
All
unanimous.
right.
Yeah.
And I think we can go on because we're running short on time for getting through everything. So. Am I taking this too? Okay.
Sure,
Next
feel
slide.
free if you'd like. Yeah.
Role of supervision. Some of the key issues in supervision. Does the clinic have supervisor availability if there's an emergency or a behavioral crisis? You know, can you access a supervisor? I know one time that just before a holiday, and I had someone in that was needing to be hospitalized, and the only counselor or the only supervisor available all the way in the whole state was the director in the state office. So I was seeking supervision from the director of the state program. The supervisor will need considerable experience in handling some of those challenging situations. So you don't want a supervisor that's just kind of an administrator. You want a supervisor that actually has good clinical experience in dealing with whatever the crisis is. Consider group supervision format, and this can help support the learning of many and provides a network of supportive colleagues. And I know one of the things I've really suggested for rural areas is that you have maybe a monthly phone call where you can bring cases in and talk about them, or have colleagues in other places. That's where conferences and regional meetings and things like that are really helpful to build those networks, that you have people that you can call and ask for that kind of support. Next slide, please. Provide your supervisee for the supervisor, provide that supervisee with the emotional support in addition to practical advice. Emphasize that the supervisee tap into their resilience skills toolbox. So get them thinking about resiliency, which will help them work with their client with terms of resiliency. And you might need ongoing supervision to process things through several times. And does the supervisee need some of their caseload distributed to others while they're dealing with their recovery from that crisis? Next slide, please. Maintain keys to a cross-cultural supervisor or supervisee relationship. If you don't have a native counselor or supervisor, how do you access one if you need it? I know I worked with a student through the Society of Indian Psychologists that at all of her sites, there weren't any other natives. And so I was able to get her linked up to a native psychologist that lived in her area. You know, maybe it was several hundred miles away, but at least they could connect and she could process through things from a cultural perspective. Acknowledge and adapt given possible differences in worldviews, values, traditions, and cultures. Be a good listener and help your supervisee be the best that he, she, or they can be. Next slide, please. And can you take the legal issues?
Sure. And I realize we're getting close to the end, so I'm going to go fast with this, but there's interesting legal topics that we can bring up in our final sharing and discussion session in a couple of weeks. So next slide. So sometimes legal issues come into play with some crises and emergency situations. It behooves you to get to know what is the various interrelationships of the local, tribal, county, state, and federal courts, because you may have to be dealing with several of them. And sometimes the issue is easily dealt with on a local level, but sometimes it might require another layer. And then be familiar with tribal policies. There's often an opportunity to make recommendations in tribal courts, and sometimes they're called wellness courts. And these courts can help move the public health perspective much faster than perhaps can be the case if somebody's adjudicated. And so wellness courts or mental health courts, some of them are called, it's a great opportunity for an individual to get quicker access to services, as opposed to having to go down the criminal justice path, where often there's not going to be much remediation or treatment. Next. So what are some of the legal situations? One is the emergency hold. As you may know, my apologies, it's probably old news for most of you, but these can last for up to 72 hours, and it's a temporary hold that confines a person in a secure, safe place, such as a hospital. The logic behind it is that the person may have a mental illness that is so severe they may not be able to care for themselves or be able to make good judgment. So the idea is to kind of put everything on pause and see within 72 hours what kind of decisions can be made voluntarily or not. And then if I'll call it a rational, healthy response to the situation is not voluntarily agreed upon, then you can take certain steps as a professional to see if you can get mandated treatment. But emergency hold is kind of that pause situation that allows some review of things and see if a rational treatment or health response can be negotiated. Next. Just more details to it. I think I just want to emphasize, it's great skills that you probably have in your counseling toolbox that can be helpful when you're trying to deal with this kind of situation, because you often have a client, you may have significant others, and you may have, you know, a legal parameter to worry about. But in many ways, you're trying to be a mediator to negotiate a good resolution to a difficult situation where somebody's mental health may be putting themselves or others at risk. But some parameters to keep in mind. And at the last bullet, I want to emphasize that the client has to be told of their rights, and so they can leave after 72 hours, excluding holidays and weekends. They have a right to a medical examination within 48 hours of confinement. So, and they also have the right to accept treatment voluntarily. Next. I'm seeing we got just a couple more minutes. And so at the other end, there can be mandated treatment where the person is committed to treatment against his or her willingness. And this usually occurs when things didn't go well in the emergency hold, when there was no voluntary acceptance of treatment, but there was still the concern by professionals that the individual needed treatment because they have a diagnosis of a mental illness, and that mental illness diagnosis and behaviors leads people to think there's a strong likelihood that the person would physically harm themselves or others. And there is no less restrictive treatment option. And inherent in that, number 3, is that the client didn't agree voluntarily to treatment, but also the concern can be that an outpatient option is not appropriate because of the concerns you have with number 1 and number 2. I think I'm going to stop there because we can discuss mandated treatment and challenges and issues people have dealt with along these lines when we have our sharing session in 2 weeks. And so I want to turn it back to Monica just to remind people about the post-event survey. So I think if you go 2 or 3 slides, Sarah, there you go. That can be helpful to people.
Yes, please take a few moments to evaluate the event today. We really do appreciate your feedback on our events. Also, I wanted to remind you about the session next week. Nelda Huskie will be talking about case illustrations that day. Thank you all so much for coming today, and I agree with comments in the chat here. It was a great event. A lot of content was covered here today, and thank you to Jacque, Kathy, and Ken for presenting to us today.
And thank you, everyone, for your great sharing.
Yeah, thank you. Lots of good ideas.